serve as the Chief Growth Officer here at JP Systems. Just want to share a little bit about our company as we begin this session. So next slide, please. So just as the background, we are a healthcare IT services firm and federal prime contractor that was founded in 1983. We provide clinical data interoperability and terminology standards, amongst other services for federal agencies. We specialize in HL7 data standards development, data architecture, clinical terminologies, and clinical data quality improvement. Next, we'll go on to our agenda for the day. So today we're going to be exploring considerations for those planning to adopt FHIR to transmit health data, right? So the adoption of FHIR requires key steps to reduce barriers. And naturally, it's great to have individuals and expertise that can help you address those specific challenges. So just in short, we're going to unpack today, what are those specific steps that you need to take? What are some of the barriers for adoption and those specific challenges? And how do you move forward from here? So just some light housekeeping about this webinar. First, please be sure to use the chat feature to share your information, perhaps what interests you have about the webinar as we proceed, and connect with others in the community today. Also know that we'll be sending all attendees copies of the presentation today, as well as video. And additionally, we'll be addressing questions at the end of the webinar. So please be sure to use that chat feature to ask questions, and we will cover them at the end of the webinar if time permits. Next, I would like to introduce our speakers today. So we have Mr. Jay Lyle, our PhD here at Chief Standards Officer at JP Systems, as well as Becky Gradle here at Health Systems Standards Specialist here at JP Systems. So with all of that, please be sure to share your company information again in the chat. And Becky, I yield to you to get started. Becky, I believe you're on mute, so perhaps we can unmute that.
Thank you for that, Brian. My apologies for being on mute.
No worries, no worries.
Well, welcome everyone to the Healthcare Innovation Webinar Series Part 1, Leveraging FHIR for Interoperability. Jay and I are clinical data standards experts who work for our clients to increase clinical interoperability. We run a FHIR community of practice to support developers on multiple projects at a large federal healthcare system. Today, we're going to use a question and answer format to highlight critical aspects of FHIR implementation. We assume our audience has a basic understanding of FHIR, which is a standard for defining how clinical data is electronically exchanged. We will share our experience with many challenges we've encountered and how we've overcome them. Let's start with our first question. The FHIR specification states that FHIR is fast and easy to implement, and that simple interfaces can be working within a single day. This seems too good to be true. When the data is straightforward or being modeled for the first time, this principle seems to apply. Jay, what challenges can arise with your legacy system data?
Thanks, Becky. Right, that's a common perception. A client may say, well, our system has a patient date of birth and FHIR has a birth date. It doesn't look that hard. In fact, most of the elements you're likely to see are present in the base HL7 FHIR specification. The idea is that if 80% of systems implement a data element, it should be in the base by the 80-20 rule. Any specific things you need that are not in the basic specification can be added, and we'll get to that in a minute. But common fields like birth date will be relatively straightforward. And I say relatively because there are still some gotchas. First, FHIR uses the ISO date format, so if you don't, you will need to transform your date format to match the FHIR one. Secondly, the FHIR data type supports dates only. If you need time, for instance, for a neonatal unit, you'll need to use the FHIR extension for birth date time. So you need to know how to do that. And third, when you're recording time in FHIR, you need a time zone. Since FHIR is designed to transmit data across boundaries to arbitrary stakeholders anywhere in the world, it makes no assumptions about the proximity of two business partners. So it may not be important that your specimen, for instance, was taken at 9 a.m. Eastern rather than 9 a.m. Pacific, but it could be. Localized systems that record time-stamped records without a time zone will have to have that locality built in.
So Jay, with what you just explained with using the ISO date format, the necessity for a time extension, and accounting for time zones, dates seem to be pretty straightforward to implement. Is there an example that might not be as apparent?
Absolutely. Terminology provides a rich set of issues. One issue arose with a client that was sending absolutely correct link codes for documents, but they had tweaked the names for their clinician interface. So the display property contained terms that were not identical to the specification display property. There is a place in FHIR for that information, the name of the coded thing as seen or captured by the user, but that would be the text field, not the display field. So here is the source specification. So there's one place here for what the user sees, and there's one place there for displaying the official name. If you go back one slide again, okay, thanks. The client could then choose, if they didn't have it, to look up the correct display value and to provide that, which would be optimal for the recipient and also for the client's business agility. Or they could choose simply to leave it blank, which would be optimal for short-term task and budget control. And if I'm going to can take a brief tangent. We do know that we will always face the tension between meeting current requirements as cheaply as possible and building capability to enhance quality and agility into the future. And our position as architects is to make sure that even when there are competing priorities, the option for agility is always at least on the table. And that if you have to allow that technical debt to accrue, you are at least aware of it.
So terminology, oh, thanks, Jay. Terminology usage seems to add an additional layer of complexity to FHIR, especially when native or legacy codes must be mapped to a terminology, and the legacy system only has the code value and not the corresponding display. What other issues can terminology cause?
Well, there are some places where specific design decisions have an effect on your implementation. Another case we had recently, an implementer was sending a code as specified by the US core. They weren't doing anything unusual or incorrect, but the Inferno test suite failed them for using a code that it did not recognize. Now, this code is in the specification, the US core, but it's in the US extension to SNOMED CT. So the testing infrastructure, which only uses the international edition of SNOMED CT, did not find it. What we're looking at here is the SNOMED guidance to build a URI for a SNOMED edition. That is, the US edition is the code system. It's not a version, and it has a US component identifier in the system URI. So there's just one here. Actually, there's two on the slide. That's because one of them is to identify just the edition, and the second one shows you the option for also identifying a version of that edition. But if we look at the next slide, this is the FHIR guidance, which is to put the SNOMED CT edition identifier in the code system version field, not as an extension to the code system URL. So this is one of those cases where there seems to be an analytically correct design solution, that is to put the US edition in the system URL, just as SNOMED suggests. But the community has converged on an ad hoc way of doing things, putting the US edition identifier into the version field. Now, some people might call that a kludge, but it is a documented design decision, and it's one of the features of the landscape we're in, so we do need to be aware of it. As an update, that code has been added to the international edition, so you will not have that problem with this code anymore. But anytime you use the concept from an edition other than the international edition of SNOMED, you will need to know this.
Okay, so it seems FHIR may not be as easy as it appears on the surface. What do you say to implementers who understand that, but think it's too hard to follow a standard?
Exactly. So at the other end of the spectrum, I hear clients saying their data is special and it seems unrealistic to try to force it into a lowest common denominator standard. So back to the 80-20 rule, it's clear that firms will have information that doesn't fit in FHIR, and FHIR supports that 20% in a couple of ways. First, clinical data is famously sparse, There are kinds of facts that are extremely rare, but extremely important for some people. So you can't build a SQL table with enough columns to represent all that information, like BRCA genes and heart attacks. The answer to a lot of these questions is to represent this sparse information with the observation resource. Observation is the Swiss Army knife of FHIR. It's a two-part semantic package with a question or a test or a property on one hand and an answer or a value on the other. So it can represent vital signs like temperature, lab results like serum sodium, and clinical instruments like APGAR scores, as well as any more specific or exotic concepts. In short, pretty much anything that you can describe and assign a code to can be communicated in an observation resource. One ramification of this is the management of codes can be quite complicated. We searched in the LOIC coding system, which started out as a lab system, but now has expanded to cover several domains and has 70,000 codes in it. We searched in here for blood pressure, and you'll see there's over 500 codes meeting those criteria. If you scope it down to systolic blood pressure, you still have over 100 options. And the lesson here is that you need clinical and data expertise to pick the right option in a case like this.
So Jay, are you saying that observation is the answer to specialized local data?
It is the answer for much of it, but there are other kinds of information that don't really fit that pattern. One feature of FHIR is that while base resources are extremely flexible and have very few mandatory constraints, most of them do have a very specific state model with a small set of universally required status values. One pharmacy client looked at those status values and said, we have twice that many status values. How do we make sure the real status value is provided? So the first thing we do is we make sure we support the FHIR requirement by mapping our local values to the standard in the required status field, as you see here. But that doesn't provide the detail that we want. We saw a minute ago how you can put a code value in FHIR and also include local text in the text property. But that doesn't apply here because this is the code element, not a codable concept element. So it doesn't have that text property for that flexibility. So we can't get that. We can't get around it that way. In this case, what we need is a brand new data element. And FHIR allows extensions for this, meaning you can include new data elements when they're not covered in the 80% supported by the core. There's a syntax for defining extensions, for inserting them into the JSON structure of the resources, and even for publishing them so recipients who haven't seen them can look them up and understand what they mean. What you're looking at here is the FHIR extension registry. You can only see a few, but there are about 700 of them in here. Now this is moderately official. It is a registry of extensions that have been registered with HL7. You don't have to register your extensions, but there are plenty of them out there. Now, back to the pharmacy case. In this particular case, familiarity with the full specification of FHIR paid off, because in these extensions defined by HL7 and published in the FHIR core, we do find the alternate codes extension. This supports exactly the case where there's a tightly defined data element like a status that has a lot of variation out there in existing implementations. So we map the specific local prescription status code to a slightly broader FHIR status code so anyone anywhere knows the general status category. And then we provide the local value in the extension for those who understand and depend on that more specific value. So we were able to meet that requirement without inventing anything new.
So with the many extensions you've shown the audience, it sounds like FHIR already has many of the necessary clinical extensions for interoperability. Is this true?
Yes, many, but not all. Another client had a field in the billing domain about the patient's billing date. And this is not a clinical observation, and it was specific to the patient's relationship with the institution. So the observation resource didn't seem appropriate. Also, the financial domain of FHIR is a bit less mature than the clinical domain, so there are not as many prefabricated options on the table. That's not a problem for JP Systems. We created a new extension for this value. We assigned it a name using a consistent pattern so that recipients will be able to recognize it as an extension defined by the sender. And we published the definition in a web-based implementation guide so the recipients can look it up and understand the contents.
So what kinds of problems do you see with the creation of extensions? Because FHIR is meant to support interoperability and not create just another point-to-point interface. Can you maybe suggest some best practices for extensions?
Absolutely, and they're based on real world examples. So here's an example of how a project team began designing extensions to support the requirements they were given. But we are able to show them how to support those requirements without inventing anything new. The data elements supported by the bottom two items in this image are actually represented in the FHIR-based specification. Now, they use different terms from what the team was expecting, which is why I guess they didn't find them. Semantically, they do what is needed. Now, the top one is not in the base FHIR resource, but there are extensions published in FHIR. If you need an element that's included here, you can use the extension that's already published, and your partners will have a much easier time understanding it. And as we've seen, the alternate codes extension supports that local status requirement. So this one was a success story. Now, the next slide illustrates that it doesn't always happen that way. A pharmacy client had engaged a major vendor in the health data space to enable the FHIR API. And when we reviewed their work, we found the implementer had created several extensions, some of which had that problem we were just looking at. So they really didn't need them at all. Extensions that encode data that's already present in the information model, they don't help share information, they obscure it. But even where the extensions were needed, and there was a new requirement, there was a problem. These extensions were defined in the vendor's namespace. Now, these elements were requirements of the healthcare system, which needs to be in control of their information assets, and which might even choose to use other vendors in the future. Binding those extension definitions to the vendor technology is a brittle and potentially debilitating design choice. But it's important to know when you really need extensions and when you don't, because adding unnecessary extensions confuses people and adds to the noise. And if you do need them, it's important to govern your design predictably and to share your design transparently. FHIR can absolutely support specialized data, and it's our responsibility to handle that specialization in a way that can be understood, can be reused, and it doesn't add noise. That's how we support interoperability.
That is great information, Jay. With the 80-20 rule and the use of extensions, FHIR can accommodate a variety of use cases, but it sounds like there might be a lot of extensions in FHIR. Can you share with our audience a bit more about this?
Absolutely, Becky, there are a lot of extensions. You'll notice that the idea of extensibility implies that the standard isn't as standard as we might like it to be. Some payloads will be pretty clear, but some will contain things that you, the recipient, don't recognize, and this is the trade-off. FHIR provides the core standards platform, and it supports extensibility, or not doing so would be a deal breaker. And the cost of this ability is variation. The extensions and the local constraints that people add to FHIR are published in artifacts called profiles, typically within implementation guides, and you need to check to see if something already exists before you create it. At least doing so here in the HL7 registry, and if you have other ways of investigating your implementation guides that might be in your domain, those as well. In fact, the excessive generation of profiles has resulted in the coining of this new term, profile-liferation. It's a real problem, and it demonstrates how important data governance is. Publishing your profiles so they can be seen and searched by other teams, and searching other profiles so that you can leverage work that's already done elsewhere. They're both key practices to minimize the creation of redundant specifications and adding to the noise.
All right, so we've talked about specific data element challenges and extending the FHIR model, but what if an organization has more than one team using FHIR? Any ideas on best practices to keep all of the teams aligned?
Absolutely. It's important to have an integrated program to nurture enterprise consensus. At a typical client, we would put together an integration communication program to help get teams aligned and to keep them aligned. So we would host weekly office hours first, so clients can ask questions in an informal context. Sometimes these sessions may be very short if no one has questions, but it is a good way to keep the teams in touch and to address issues with resources from a variety of perspectives on a variety of teams. Having these cross-team meetings helps ensure these teams agree on consensus design decisions. We manage a ticket list, so clients with difficult questions can stay informed on progress, and we can quantify work efforts for the managers who need that. At one client, we did discuss using the HL7 JIRA implementation for ticket management, but that was internal development, not a standard that we're going to ballot, so that communication belongs in-house. We publish design decisions in a FHIR implementation guide available on the web, so clients unable to attend meetings can stay informed, and even clients who are up to speed have a consistent reference to refer to. We host monthly educational sessions for cross-enterprise sharing of lessons learned and technical solution ideas. These can help teams discover related projects and coordinate their efforts. So the guide, the meetings, the tickets, all of our communication channels are integrated and managed so the messages are consistent. The designs support all the participants' requirements, and even teams that never come to office hours can discover that consensus design and follow it, or if it doesn't meet their requirements, they can raise issues in the ticketing system.
So it sounds like you've utilized meetings and a tracking system, but what else can you suggest for keeping teams aligned so that implementing FHIR isn't such a burden?
Right, so the main foundation for alignment is having an objective reference so participants can tell when they're in line and when they're not. The implementation guide is our objective reference. Not that the decisions in it weren't arrived at by debate and consensus, but it is a persistent artifact you can refer back to and log tickets against. So data governance itself isn't really a problem that's specific to FHIR, but the ability to publish this kind of guidance adds complexity to your project integration task because suddenly that information is shareable and it acquires enterprise implications beyond your project. Looking at this illustration, by the way, we know you can't build a truck on a sports car chassis, but the metaphor implies that you can build diverse applications on a common information model. So the good news is that after 2 prior architectures at HL7, FHIR has adopted what they call the we eat our own dog food principle, and it aggressively uses technology to support integrated conformance, testing, and publication. When you take a high-level generic FHIR resource and you add your own enterprise constraints and value sets, you profile it. You can publish those profiling decisions in an implementation guide. That implementation guide is actually a defined FHIR resource. Written in a structure definition resource. And the constraints you define are written in FHIR structure definitions. And the FHIR publication machinery converts all that content first into a website so any team anywhere can read it. And then it provides all those constraints in a computable form. So your instance can report what profile it conforms to, and then the testing infrastructure can tell anyone in the world whether or not that instance meets the criteria that it claims to meet. So if your patient resource claims conformance to the US core, but it uses a race code that US core doesn't recognize, your resource will fail conformance testing. So what you're looking at here is the chain of constraint. So how FHIR core and US core specifications progressively constrain the information model. So on the top, the FHIR observation resource is actually a constraint on a more abstract type called the domain resource. The domain resource is where things like extensibility and metadata live, things that are common to almost all FHIR resources. And observation takes that set of common functionality and adds things specific to clinical observations, like observation code and value, effective time, specimen, that sort of thing. Then on the bottom, we have the US core implementation guide, which defines several profiles on observation. The one we're looking at is the US core screening assessment. And I don't know why it doesn't say that on the left, but that's just how it's published. The constraints in the US core are based sort of on that screening assessment profile, and you can test your resources against it if they assert conformance to it.
So if I understand what you're saying correctly, Jay, it sounds like FHIR can have 2 layers, the base resource and a profile on that. What if a team wants to use US core, but have some of their own specific requirements? Can you share how FHIR supports that for conformance and interoperability?
I can, and it goes back to the profiling process. So we had talked about extensibility, and it's good that FHIR supports it. But the core specification is so loose that profiling isn't just allowed, it's really necessary. Since FHIR is a global standard, it doesn't tell you things like how to use the OMB race codes. The US core IG tells you that sort of thing, but it's still a threshold, sort of a minimal data set that you need when exchanging information in the US. The US core IG, like most IGs, and IG, by the way, is the abbreviation we're using for implementation guide, asserts constraints but it does so in a computable way you can use to guide your development. So you always know that if your data conforms to US core, it should be processable at some level like any other organization making that assertion. But you refine your own implementation, you can do the same thing, publishing your constraints on US core and a guide that your whole enterprise can align with. So the first team to tackle your lab-like codes may be the only team that has to do any work on that. All the subsequent teams can adopt that work already done, or of course, point out any additional requirements the first team didn't have. The US core IG, like all IGs, is published as a website that anyone can review, and it also includes these machine processable definitions. So there's no limit to the number of layers we can have here. You can use this capability to develop your own organization-specific or use case-specific IG or IGs to coordinate diverse application development teams who can always see that enterprise governance and use it to test their working code. You can even use it to interrogate the quality of incoming data, possibly as part of, say, a partner onboarding program. Tool hosted by the Office of the National Coordinator. It's called Inferno. You pop your resource in this page and you select the IG or profile that you conform to, and it creates you. So this is the quick and easy page. There are ways to configure system testing in this site. It's automated, so it's easy to do the right thing. So you wind up with better data governance and better data and better care.
So standards such as FHIR seem to be great for keeping everyone on the same page to achieve interoperability, but they also seem to be a moving target if there are changes. How is this handled for implementers?
Right. One thing to keep in mind is while standards strive for stability and predictability, they do evolve over time. The designers strive for backward compatibility and to avoid breaking changes. And to date, we haven't seen too much of that. But there are areas where guidance is immature. Now, partly this is a result of the industry. It's a private sector industry composed of competitors. So there's going to be disagreements and conflict. And in some cases, this means that delay is better than a premature consensus. And in others, it means it's going to take too long. It's unnecessarily lengthy. This is one reason it's important to stay engaged with the standards development organizations. Knowing how the conversations are going can help you effectively broaden your designs to keep known options open. In fact, Becky, I believe your work in microbiology illustrates this very point. Can you give us a quick overview?
Absolutely, Jay. So microbiology is an example of the slowness of standards development. When I was mapping legacy microbiology data to the FHIR standard for a client, I found in FHIR chat, or otherwise known as Zulip, that some international standards implementers were asking the FHIR community how they should be in alignment with grouping panels. Long story short, the discussion went on for over a year until the standards community realized they needed to make some decisions. The slide we're looking at is how the standards community proposes microbiology information should be grouped and connected in microbiology, but to this day it has not been formalized. Added to the complexity is that legacy system data doesn't always fit neatly into this model. Some implementers are utilizing this model, so we chose to follow suit with our maps and our clients so that we were in alignment with systems that we may exchange FHIR data with. All right, back to the next question for Jay. In addition to the fact that standards development takes time, let's talk about how regulations can impact how FHIR is implemented.
It's important to know not only the current policy and regulations, but also where those regulations are headed, so you don't wind up on the wrong page a couple of years down the road. Even in cases where the solution is agreed to, it takes time to test, document, vote, publish, and get into regulation. The image we're looking at is used by the lead designer on the US Core project to illustrate the relationship between the US Core FHIR design specification and the US CDI requirements. That's the US Core data for interoperability data elements that are determined by the ONC. At each iteration, one of them gets a bit ahead of the other, but they wind up trending in the same direction. So that's the humorous presentation of that fact. Neither the US Core specification nor the US CDI requirement list is ever the last word for very long. This illustration is maybe a little more useful. It lines up the annual updates to US CDI with the annual updates to FHIR US Core. It looks pretty scary. There's a lot of releases on there, but every version of US Core does not make it into regulation. R6 is the current specification, but it'll be a while before that changes. I wouldn't expect to see the next version be anything under 11. Now, we're not fortune tellers. We cannot tell you the future, but we are plugged into the standards development process. When one client found their resources getting rejected by the testing tools for invalid CPT codes, we were able to work with the HL7 terminology team to determine that the AMA was only providing current valid CPT codes, valid for recording new data to the testing team. We were able to work out a plan for the AMA to provide legacy codes so that historical data could be transmitted as well as new records. So when developing FHIR capability, you're going to want partners who are familiar with the standards development process and with the players involved so you can get a better understanding of where things are likely to be going. At JP Systems, we are fortunate to have a couple of people who have served as HL7 co-chairs long enough to be fellows, so we do know the people and the process.
That sounds great, Jay. So some teams feel like standards are a burden to adopt, especially if they do not have team members who have experience with the FHIR standard. What can you suggest so we are achieving interoperability and not just building another point-to-point interface?
Yes, let's be clear, adopting a data standard is not easy, and anyone who takes it on should take it on for good, known, and well-understood reasons. Those reasons may be constraints like the ONC and CMS policies for certification and payment, or they may be the dictates of an important partner or client. The main value that drives these regulations is value for the patient. Standard data makes it easier to coordinate care across diverse provider institutions. We often come across cases where it seems like a small deviation from the standard would be convenient, and I won't say that's never appropriate, but the point of the standard is to be intelligible to partners who weren't involved in your interface development. If you add unexpected wrinkles, you block those partners out and you've wasted your time and effort. There will be times when you need to zig or zag, but you need to make sure that any out-of-band partner is able to understand your transmissions, because spending effort standardizing partially is a waste of resources. But there is real value in using the standards that you can realize within your enterprise.
So Jay, I heard you mention that there's real value in using standards. Can you share with the audience what kind of value standards offer?
Absolutely. So first of all, just having a standard will help you govern your data across a large and diverse enterprise. Any standard can provide that kind of baseline. FHIR is just one that happens to make it easier to communicate. Second, that standard view also helps you coordinate with partners. If you need a new integration point with a partner and you already understand 80% of what your partner is saying, that's a win. Using a profiling stack that lets you share decisions and test based on published designs makes that even easier. Third, standardized data supports a wide variety of secondary uses, including research, quality management, public health, claims processing. Not only is it easier to communicate with these organizations supporting the uses if you have standardized data, but the leading edge tool sets designed to support those use cases also use the standards. Finally, by making that data easier to exchange, you support better quality of care for your patients or your partner's patients. The most common cause of patient harm in healthcare is medication errors. This results from providing care without having the right up-to-date information. Better data means safer patients.
Jay, these are all great things to be aware of for FHIR implementers. What last pieces of advice can you offer the audience?
As with any question about how you're going to use technology to support your corporate strategy, the first step is to make sure you have clear business objectives and use cases. This part isn't any different from any other kind of initiative. Second, understand that adopting standards aligns your corporate information assets with an external framework. Now, you may commit to complete transformation of your data infrastructure, or you may maintain a rigid separation, but either way means strategic decisions about data governance and a new concept of operations where governance needs to be part of the process. Anytime new information elements are identified or pursued internally or externally, decisions will be required. That's a little abstract, so take an example. Say your facilities manager changes the way they identify facilities. That changes the data going into your communications. And even though you adopted a standard, so you wouldn't have to have this discussion with every partner, you need at least to have that discussion with your interface team and to notify all of your API clients. So third, you need to define the processes that will change and the standards that will support that change. These processes and standards will both evolve independently, but they need to remain aligned so change from either side, inside or outside, should be accommodated. Those processes need to recognize and support enterprise data governance and communication. So for the parts of that plan supported by FHIR, there should be continuous integration testing available to ensure consistency, and again, to make it easy to do the right thing every time. Finally, we probably want to make sure your internal standards team to develop your internal standards competency. And if you don't have the size or wherewithal to do that, make sure you have the right partners with experience in FHIR implementation as you embark on this journey.
Jay, that was really great information. Thank you for sharing that with the audience. And now we're going to turn it back to you, Brian.
Well, good day again, and thank you everybody for attending today's session, right? So just some basic information here about us, right? So again, we look forward to collaborating with any of you in our specializations, right? So we have a list here of areas that we have been focusing on for many years, built some pretty significant past performance and in supporting our federal agency partners. And so additionally, one of the things I want to ask as well is that be sure to reach out to us if there's an opportunity where we can be of collaboration. And again, we appreciate you taking the time to join us today. Be sure to reach out to us via email at info@jpsys.com. And again, have a great afternoon, and thank you very much for joining us today. Thank you.